is my experience with the HFVI intraoperatively. I'm going to share with you some cases that I've done. So first, we're just going to talk about some of the logistics. Dr. Osborne already went through a little bit of this. We'll talk about how I use the machine intraoperatively and then some clinical cases that I've done. So again, there are some people for which ANI should not be used, those not in normal sinus rhythm, those with irregular respiratory pattern, or those who are apneic, and then patients who have implanted pacemakers or have had a heart transplant. So like Dr. Osborne mentioned, the monitor is very easy to use. It comes with a clamp that goes onto your IV pole, and all you really have to do is place a sticker on the patient's chest, rather two stickers. The rectangular one goes just below the clavicle on the right side of the chest, and then the round one is about V5. And like she said, the patient can be prone. The only time I've ever had a problem with this setup is when the patient was having a sternotomy and my sticker was in the surgical field. I was unable to do that case, but in 99% of cases we have no problems putting the stickers on the chest. And then just a tip for you, for those of you who have patients that have a lot of hair on their chest, you don't have to necessarily shave it, but it helps to add a little bit of lubricating jelly and then place some tape over the electrode. And that will help maintain the signal, especially in cases like robotic cases, where after the robot is docked, it's going to be very difficult for you to reach under there and mess with the leads. So right when you turn your machine on, it will go through a period of initialization. So I tend to plug it in fairly early while I'm putting in my other monitors, because this can take a minute or two. And then you want to make sure that the quality signal is good. I don't start the case until I get a good quality signal, because I really like to see the beginning of the case, sort of what the patient's baseline analgesic state is and how they respond to the induction of general anesthesia and intubation. So I want to wait until I get a really good signal before I start the case. And then the machine is plugged into the wall, so it has electricity. But if it inadvertently becomes unplugged, it does have some battery life, and each one of these bars will last you about 10 minutes. So if you start noticing that they're getting low, you have to plug it in. And then last but not least, if you plan on extracting data from the ANI monitor, which you can do, it spits out a very nice spreadsheet of all the numbers. If you plan on correlating that with hemodynamics or medications given or patient pain scores, any sort of research, you must make sure that the time on your monitor matches the time on your electronic medical record. And I say this because I really learned that the hard way. I had to manually fix a bunch of times. So here we go. So now we have a good signal. We're getting started. The number in orange, as Dr. Osborne mentioned, is the mean HFVI number. And I think it is averaged over about 120 seconds or so. And then this yellow number is instantaneous. So it moves faster. So if you look to your left on the chart, you will see that the yellow line is a more volatile line, if you will, than the orange line, which is basically a smoothed out version of the yellow line. So, for example, in this case, right when we put the monitor on the patient, they had a baseline ANI number of about 70 or so. We gave them 100 micrograms of fentanyl to pre-medicate, and then proceeded with induction. You see that there's a little dip right there, sort of with the, I guess you would think that being induced is a little bit frightening or noxious for the patient. And then you see a very large jump up, almost to 100. And that, I think, is very telling for patients who are very opioid sensitive and also have a high parasympathetic tone because you've just induced general anesthesia. And then, of course, you see this rapid dip because I happened to be working with a medical student that day, and the laryngoscopy was probably a little bit more prolonged than it would have been otherwise. So that kind of, the ANI is very nice in this way because it sort of tells a story. On the bottom, you'll see the timestamp, and each rectangle is about 5 minutes, which is pretty good because I usually tell my residents to watch the numbers, and if it's still in that same range in 5 minutes, then we make an action. What I like to teach my residents is that the HFVI is not like the pulse ox. If your pulse ox goes from 99 to 92, that's very alarming, and you should do something very quickly. If your HFVI goes from 52 to 33 over 5 minutes, it's not of the same sort of alarming value as a pulse ox. You can sort of let things ride for about 5 or 10 minutes before you act on the numbers. So this is a case of a patient who was involved in a MVC, multiple injuries, splenic laceration, liver laceration, multiple broken bones, things like that. This was after he had been in the ICU for about 3 days and coming back to the OR because his abdomen had been left open with a Abthera device and they were washing things out. And during the case, he was tachycardic and hypertensive. And he had a lot of medical issues going on. He had been intubated for the last 3 days. He was a multiple trauma patient, and he had been on a fentanyl drip in the ICU for the last 3 days. So certainly he had some acute opioid tolerance. So the question then is, are these hemodynamics that we're seeing right now due to inadequate analgesia? So we look to our ANI, and this wasn't this exact case, but we'll pretend that it is. These numbers, 73 and 80, illustrate that the patient at this moment seems to be at a good level of analgesia. And you can see that about 5 minutes ago or so that fentanyl was injected, and then the yellow line tends to be a bit volatile. So sometimes it's nicer to track the orange one. And you see this nice peak onset of fentanyl, 5 minutes later. So it's very nice. There are circumstances. So in this patient with the current hemodynamics, I would say that it is unlikely that his hypertension and tachycardia at this time are due to inadequate analgesia. There may be a problem with his ICP. He may be getting SIRS symptomatology on moving the patient from the ICU to the OR table. The resident may have dropped the A-line transducer, and all of a sudden it's on the floor, and everyone thinks the pressure is high, and it's really not. You just pick up the transducer. So I think it's something else. But at this time, I did not think that it was appropriate to give additional opioid or other analgesics. Okay, now let's pretend that this is the exact same case, but when you look at the HFVI number, instead of 80 and 73, you now have 43 and 20. So this is telling a completely different story. I had to make up this one, so the graph doesn't match. But let's just use the numbers and say, well, the 20, that means instantaneously it's dropping. The patient is experiencing some sympathetic stimulation. And then the orange is just following behind that. In this case, I would say that the current hemodynamics with the tachycardia and the hypotension may very well be due to inadequate analgesia. And I would try to increase the patient's analgesia and then see what happens with the HFVI. So it's just another tool to tell you in your assessment of the clinical picture what's happening with your patient. So now we'll take a different case where the patient is hypotensive. pain control and inflammatory cascades and all those wonderful things that Dr. Burgess was talking about, chronic pain and all of those things, well, that's probably not on the front of your mind when your monitor looks like this. Right now, you're thinking, oh, what just happened across the field? Are we bleeding? Is something going on? Can we resuscitate? So after the patient is adequately resuscitated, it's important to then go back to the ANI, because it's not mutually exclusive that the patient can be under resuscitated, but also experiencing inadequate analgesia and the inflammatory cascade that Dr. Varghese explained. So they're not mutually, you have to remember that just because their blood pressure is low doesn't necessarily mean that they're not also in pain. So I wanted to highlight this part on the ANI for those of you who are going to use it, because it's a very user-friendly device. I would say that within the first 3 to 5 cases that you use it on real patients, you understand the machine, you understand what the numbers mean and how to interpret it and how it's sort of predicting what analgesic state the patient is going to be in. But in any case, there are these parameters on the lower right-hand corner. And sometimes during periods of hypotension, like I showed you in the previous slide, the ANI may be low. So here, the ANI looks like it was about 40 or so for a few minutes. Because a lot of the cases that I participate in are research cases and we have to follow a protocol, it says that if the ANI drops below 50 for more than 5 minutes, give X, Y, and Z. So we mark when we don't give X, Y, and Z, basically when we deviate from that protocol, because the patient was hypotensive at the time and I'm doing other things, I'm not going to give additional analgesics at this time. So the monitor is very user-friendly and very helpful for marking when things happen, and then you can export the data and match it with the data from your EMR, which is a very, very large spreadsheet that you then hand to a statistician, hopefully. So the last case that I want to discuss with you is a 56-year-old woman who came in for an open abdominal hysterectomy. She looked pregnant, but in fact was not. She had a very large uterine fibroid. She had a history of diabetes, mild hypertension, was an occasional smoker. And in our preoperative area, as part of our ERAS protocol, the patient was given 600 milligrams of gabapentin and 1 gram of acetaminophen PO, and then brought into the OR and underwent a very standard induction that we commonly do with the drugs that you can see here. And it took them about 3 hours to get this very large fibroid out of her. And I think the ANI did not go below 50 very much. I will show you this picture here. So this is not from that exact patient, but it's representative of that case. I think maybe 2 times for within a 5-minute period, and you have to remember each of these rectangles is only 5 minutes, she dipped below 50, but that was it. So for the rest of a 3-hour case that was an open hysterectomy, she was what we call riding high. She was in the ANIs of 60s, 70s, 80s. And the few times that she dipped below 50 when they were sort of everting the uterus out of the abdomen, which I think, is a very noxious stimuli. And my resident and I were sitting there trying to have a nice conversation about, what is pain? Why do people have different pain perceptions? Was sort of one of those philosophical talks. And then he said, I'm not really sure I believe this machine, because there's just no way that this lady is having an open hysterectomy and it's been 3 hours and we've given her basically 100 of fentanyl, of opioid, and the gabapentin and the acetaminophen. And I said, let's trust the machine, let's do what it says, let's follow the protocol. And if she wakes up and is screaming in pain, we'll throw the machine away and send it back to Nacho. And So we followed the protocol and did not give the patient any additional opioids. And she woke up in the PACU and was just as happy as could be. And it really hit me then, because I thought, if I didn't have this machine during this case, I for sure would have given her more fentanyl, because I would say on average for these sort of open cases that my colleagues and I do, if you pull our data, we're probably averaging about 250 mics of fentanyl. And, I think in terms of opioids, like Dr. Varghese talked about earlier, you want to give the minimum amount necessary to prevent pain and the inflammatory cascade that follows those sort of inflammatory mediators. But of course, we don't want to overshoot either. And at best, in some circumstances, we are giving our best educated guess. And in this woman, I think I probably would have given her more fentanyl, and it would have been too much for her. She may have had a, slow emergence or some respiratory compromise in the PACU. I mean, I'm not really sure. But I really appreciated that the machine kind of helped me manage her intraoperative case here. So just some take home points. We have so much technology on our hands these days. And when I first got this machine and I tested it out on a few patients, I thought, it's pretty cool. Like, that's nice. But the more I used it, the more I began to rely on it. And then you sort of, at first I was only using it for my research cases, but then when I was doing my normal, not research cases, I was sort of longing for my ANI, and that I think speaks to the usefulness of the monitor, that I actually wanted to use it for my regular clinical care. And then in my institution, we haven't really moved to this opioid-free technique where, it's no opioid at all and you're running several infusions. We do try to be opioid sparing and maximize our use of regional anesthesia whenever possible. But I do want to mention that the Hfvi monitor can be used during opioid-free anesthesia when you're running infusions of dexmedetomidine, lidocaine, magnesium, all of these multimodal sort of recipes that Dr. Mollier and his colleagues have sort of pioneered. And then hemodynamics do not always reflect the surgical stress of the patient, right? We use that sort of as a surrogate marker, but it really doesn't tell us about what is happening, on the inflammatory cascade and pain otherwise. And then, like I said, what we do, without the ANI works most of the time. Sometimes we undershoot a little, sometimes we overshoot a little, but I think we can always do better. And I really like this machine because I first started using it for research, and now I want to use it for all of my normal cases, because I really feel like it allows me to titrate my intraoperative analgesia much, much better, and to tell if a block is working. I can tell the pain team, like, oh yeah, your block is good because, this guy's riding high the whole time. Or, new resident on the rotation and, patient's not doing so good with their AV fistula under a MAC. And I can tell, like your block is not working. So future directions, multimodal approaches, I think that's where we are moving with anesthesia as the pendulum swings in life. We are swinging away from opioids and more toward non-opioid adjuncts. Many surgical subspecialties have created ERAS protocols designed to prehabilitate patients before they come into the hospital to sort of get them in tip-top shape, and then do everything we can in a multidisciplinary approach to take the best care of that patient and have them get home as quick as they can. And all of this sort of matches into that very well. As you all know, and as Dr. Varghese mentioned, we have an opioid epidemic in the United States. We have, 500,000 people who have died from overdosing. And we have patients who come in on large doses of opioids. And we sort of, during the case, we don't really know where we are in terms of their analgesic state, right? Because they're so tolerant. And then we give other adjuncts like dexmedetomidine, lidocaine, and then with the ANI, we can sort of see where we are. And then another interesting thought I had not too long ago was that when I was in the COVID unit taking care of a patient, they're so isolated. We don't check on them like we do with normal ICU patients. They're just sort of on a ventilator, and we sort of, adjust the ventilator settings from outside the room, and they're just sort of locked away in that box. And I wonder, if we could apply the ANI technology to make sure that these patients are truly comfortable while they are being treated for their COVID. So those are just some future directions that I had thought of. And I will turn it back to Nacho.
So thank you very much to all of you. I think it has been a very, very interesting presentation. Now I am going to open the question and answer mode so the audience could make their own questions. Well, I've just got one here, which is, I will read it for you. It says, do you see any benefit using Hfbi in outpatient surgery? I don't know if any of you could answer.
I can speak to that a little bit because we're just starting to do, I work occasionally in our ambulatory center, and they're starting to do same-day spine surgery with a very elaborate ERAS protocol. The patients are not supposed to be complicated, but they very often are on pretty significant amount of opioids for a one-level discectomy. And we're planning on using it for these patients, mostly to confirm that our ERAS protocol is going to work for these particular patients. But yes, the plan is to get them comfortable enough to go home for that day. And I think it could be, it depends on, I guess, the duration of the case and if there's going to be pain that you're concerned about.
Any other comments from you, Tiffany or Sergio?
No, I think it could be used in the ambulatory setting because, we are pushing the ambulatory envelope every day. Cases that 5 years ago would not have been ambulatory, we are doing now. A lot of, morbidly obese patients that are, ASA 2.5, 2 1/3 kind of patients. And I think the ANI is helpful in those patients because it just allows us to titrate our analgesia better so that we don't, overshoot.
Mm-hmm. Yeah, I might add as well that there has been recently a publication made in, I think it was in the Clinical Journal of Monitoring and Computing, which was just an observational study in saphenectomies. And the doctors conclude that it was just an observational study. I mean, they were just gathering patients, and later on they look at the values of the ANI monitor and the time that the patients were discharged, right, from the unit. And they showed that those patients who had a higher percentage of ENI during the surgery, over 60, they had a lower time in the post-op unit than those who had a lower ENI. So it means that, you were treating the patients, and obviously some of them hemodynamically guided, because the ENI was blinded, right? And they showed that those in which by lack or by whatever reason they were having higher ENI values, they had 11% less time in the PACU than the other ones. So this is an interesting data as well, although it's just an observational study. Obviously, it's not a randomized controlled trial with all the problems that it may have. I have another question here. Can the ANI electrodes be applied on the back of the patient to accommodate chest procedures? Any
Good
of you have
question.
any
I haven't tried
experience?
it yet.
I tried it for a thymectomy, and it did not work very well. The signals were bad, and I don't know, it didn't work very well for me.
Mhm. I might say that
Nacho may
when
know this.
yeah, I tried several times, especially Tiffany. You were talking about a case that you had right with an sternotomy, and obviously you cannot place the sensors where we normally say. So what I do is I put them on the shoulders, and I especially look for a bone because the bones are the ones that are really transmitting better the signal. So as long as you get an ECG wherever you put the sensor, that might be good. I mean, in children, in very small persons or elderly people, even I get some signal just putting on the on here on the wrist even, but this is very unlikely. Normally I just use the shoulders, which normally it works more or less okay. I have another question. Is there a benefit for the monitor go with the patient to pack you? So I mean that he's asking about the use of ENI or HFBI in awake patients. Do you have an experience on that?
I've been tempted to do this when I'm covering PACU and you get called to see with someone, they're saying, I'm in pain, I'm in pain, I'm in pain. I've been dying to put it on and see if it's validating, but I don't think it's going to be very good because you have to have a very regular one respiratory pattern. Two, I honestly I have used it for several sedation cases, and if the patient is on dexmedetomidine and they're breathing at a regular respiratory rate, you will see any particular changes, particularly when they're going to do something very, very painful. We do a glycerol injection for trigeminal neuralgia. And I was able to demonstrate it intraoperatively. Yes, it was very, very painful. The surgeon didn't think it was painful, but the patient certainly was complaining, and we could see the response before she, jumped off the table and pulled it out of her out of her face. So
Yeah.
I don't know yet if it's going to be useful for PACU. And once again, I think it's really the way that the information is generated. But maybe if you had a very calm person, I don't know, maybe in your pre-op experience, Tiffany, do you see the people who give you a heads up that they're more reactive, their sympathetic tone is greater than their parasympathetic?
Yeah, I mean, we put it on pre-op. So different, it is kind of interesting to see some people, start at 40 and some people start at 80. And I did a few cases where I took the ANI on the patient to the PACU, which is sort of cumbersome because it's sort of a big monitor and we're holding it, and it doesn't help for awake patients in the PACU because even when the patient is hurting and they're asking for pain medicines and then you point to the ANI and you say, but sir, your ANI is 70. Like it doesn't help. Like they still say that they hurt. So you can't really, it doesn't do anything.
Hence
Yeah,
the
I
difference
totally.
between pain and nociception, right?
I think that pain is a much complex concept, and it may have a lot of different other factors that may interfere on that. I just may tell you something that it happens here in Hospital San Sebastián de los Reyes in Madrid. That was a lady who was gonna have she had a breast cancer, so she was gonna have a mastectomy, a radical mastectomy. So we went into the OR. We were managing the ENI and the remifentanil and propofol. It was done with TCI. Everything was perfect. So the patient went into the PACU and I waked her and she started crying, she saying that she was painful, etc. And as you said, Tiffany, the ENI was on 70. So you were saying,
Yeah.
come on, you don't have pain, all right? You cannot do that. So but then the doctor went for getting some medicine, some pain medicine for the patient, and I was just there and started to talk with her. And she said, well, I said, what's going on? I said, well, I just went through a mastectomy and I have a lot of pain here. And I said, well, you know what happened? The surgeon, in fact, didn't do a mastectomy, but just an endolectomy because it was not needed, the mastectomy. So I said, no, but you've got your breast because it was just a nodule. And she just get the sheets, look at his breast. He realized that he had his breast and the pain stopped completely. So I wouldn't never say that that patient was not suffering pain. She was really suffering pain, but it was not exactly what we mean, right? So yeah, I agree. I mean, the control might be the patient when the patient is awake, obviously, because pain is something more than just nociception, right?
Yep.
So I think I have another one like here. It seems that most everyone agrees that there's some connection with using high dose of opioids during surgery to increase. Sorry, I'm gonna move the screen. In post-op pain and chronic pain, but anesthesia may not see this as the patient is not a long-term patient for the anesthesia provider. Is it the surgeon that needs to be convinced?
Good question.
Yeah, I think I think it's a balance. So what we know is that if you have acute pain and you don't treat acute pain, you have more chronic pain. So that's an early observation, and it got to be taken very serious in some cases, like breast surgery, thoracotomy, cardiothoracic surgery is up to 50%. So that's observation number one. Now we are learning, as I point in my lecture, that maybe that the opioids may modulate in a negative way these pathways and may increase pain. Again, hyperalgesia, I think, is being proved more or less consistently. Acute pain, there are a few papers in there. In chronic pain, there's very, very little, mostly animal data. Most of the chronic data is more related to recovery and chronic opioid use, but that may be related to other things like prescription patterns or God knows why people would use opioids. So again, I think the first message that I want to make very, very clear is that acute pain should be treated very well, and that opioids still having a role in the treatment of acute pain because that's going to minimize chronic pain. And the second part is that it just we probably have emerging data on minimizing the utilization of opioids because may have a negative impact.
Mm-hmm. Yeah, for sure. I got another question here from the other side of the ocean. Subjective against objective expression of pain. Which do we treat? It's a little bit philosophical, I guess.
Both. Pain is pain. So I think in your example, very clear is we feel pain differently, and it's the fourth vital sign, right? So we need to treat it. We need to be very sensitive to what people feel. Now that doesn't mean that we cannot optimize treatment, and that doesn't mean there are other alternatives than opioids. But pain should be treated.
Yeah, sure. Okay, thank you very much. I think that we already arrived to our 1 hour and a half webinar. I want to thank to all the attendees to be listening to this very interesting new ideas, which is basically pioneers. You, Sergio, Irene, and Tiffany, you are really pioneers that are helping us to advance and to get further in these ideas of anesthesia, pain, nociception, etc. So hope you have a very good evening, and thank you very much for participating in this webinar with us. Thank you.
Thank you for having us.
Bye.
Bye.